Hi, I'm Dr. Catherine Diefenbach, Assistant Professor of Medicine at NYU Perlmutter Cancer Center, and I will be speaking today on Beyond Transplant Novel Therapies for Relapsed and Refractory Hodgkin Lymphoma. So as we know, Hodgkin lymphoma is really a success story. However, up to 30% of patients with Hodgkin lymphoma will either relapse from initial therapy or have primary refractory disease. And for these young patients, only patients who really can achieve a CR with second-line therapy are able to benefit from autologous stem cell transplant. So that means we still have a substantial fraction of young Hodgkin lymphoma patients who we're not curing with standard therapy and/or high-dose therapy and stem cell rescue. In fact, in a cost per death analysis, Hodgkin lymphoma had the second highest life years lost of any malignancy throughout Europe, primarily due to the young age of our patients. So new therapies are desperately needed for patients with relapsed and refractory Hodgkin lymphoma. When you have a patient with relapsed Hodgkin lymphoma, we need to understand the patient in the context of how they relapse. So relapses are not all alike. A patient may present with florid systemic relapse 6 weeks after the completion of initial chemotherapy, or a patient may present with single or stage 2 relapse more than 3 years after therapy. These patients obviously need very different approaches. But today, autologous stem cell transplant remains the best curative option for relapsed patients who can achieve a second complete remission prior to transplant. However, we know that for patients who do not go into autologous stem cell transplant in a complete response, the cure rate is only approximately 30%. So we need to do better at getting patients into a complete remission prior to transplant and in curing more patients. Some of the exciting drugs that have been explored to optimize CR prior to transplant include the antibody-drug conjugate brentuximab vedotin, or Adcetris, which in a more heavily relapsed population had a CR rate of approximately 34% and an overall response rate of 72%. Interestingly, long-term data shows that a small fraction of these CR patients appeared to have sustained progression-free survival on Adcetris alone. However, for all the PFS patients and most of the CR patients, further therapy will be needed. For patients who are able to go into transplant and obtain a CR, the Athera study showed that maintenance with brentuximab vedotin improved PFS over patients who did not receive maintenance. However, it improved maintenance primarily for the highest risk group of relapsed patients. That's patients much more like the one who relapsed with a short remission duration within 6 months of therapy and had a systemic relapse. Patients who were considered to be low-risk relapse did not have the same benefit to brentuximab vedotin. Other exciting new therapies, such as the checkpoint inhibitors, nivolumab and pembrolizumab, have a very high overall response rate in relapsed Hodgkin lymphoma, although a low CR rate in the 9 to 17%. However, it does look like for these CR patients, a sizable fraction of these CR patients appear to have a durable CR up to a year. Novel combinations have been explored, including in the first-line setting comparing brentuximab with bendamustine or with standard ICE chemotherapy, as well as with nivolumab, and in the first and later line, brentuximab has been combined with both nivolumab and ipilimumab, the checkpoint inhibitor, as well as the anti-CTLA-4 inhibitor ipilimumab, as well as with both agents. We were able to show in the brentuximab nivolumab trial that I'm leading through the ECOG-ACRIN cooperative group in the US that the combination of brentuximab and nivolumab had a CR rate of 62%. So this is compared to brentuximab alone, which has a CR rate of 34%, and nivolumab alone, which has a CR rate of about 13%. So a CR rate that was substantially improved over both alone. While this is still in clinical trials, both this and a frontline data, which has very similar, a frontline study which has similar data, confirms that this is a potentially very exciting combination. Longer follow-up of the PFS data is going to be needed to show whether this can obviate the need for an allogeneic stem cell transplant in patients who are highly relapsed. And the combination of brentuximab nivolumab is going to be compared in a randomized phase 2 against the triplet of brentuximab nivolumab, ipi, and ipilimumab in a nationwide study in the NCTN that I'm going to be leading. Other drugs that have activity in relapsed Hodgkin lymphoma include the mTOR inhibitor everolimus, lenalidomide, and some of the HDAC inhibitors. All have small phase 2 studies that show that they have activity in relapsed and refractory Hodgkin lymphoma. What about CAR T cells, you may ask? They have such exciting activity in diffuse large B-cell lymphoma. Well, the CAR data in Hodgkin lymphoma is not really at that level yet. There have been 2 small studies reported. One was a CD19 CAR that was reported last year at ASH and did not really show particularly striking activity, with one PR that had a very short response duration. CD30 CARs were looked at in a small phase 1 study. There were 2 CRs that were sustained in the patient population, but these are early days and there hasn't really been yet a large-scale trial of any CAR product to date that looks like for patients who relapsed after allogeneic stem cell transplant, it can give them a durable response. So I think the take-home message for relapsed and refractory Hodgkin lymphoma is that not all relapsed patients are the same. It's important to understand the patient in the context of their relapse, their prior treatment history, their performance status, and their preferences when deciding between checkpoint inhibitor, stem cell transplant, combination therapy in the context of a clinical trial, or other novel therapies. But I would say to all patients with relapsed Hodgkin lymphoma that there is certainly hope on the horizon. There have never been more therapies that give us the option to extend remissions and life for longer than we have at the present time.